series. I'm very happy. I'm Mariam Tavakoli from Swiss Tropical and Public Health Institute. I will be moderating the session, and I'm very happy to introduce our guest speaker for today's session, Dr. Chinwe Lucia Ochu from Nigeria Center for Disease Control and Prevention. And she will be sharing with us the findings from the study about integrated mortality surveillance in the United States, Colombia, and Zambia, facilitators, barriers, and lessons. Before I hand over to Dr. Chinwe, just some rules for us. We will not interrupt the presentation. The presentation will go around 30 to 45 minutes. And after that, we will have an interactive discussion for 10 to 15 minutes. You can raise your hand and unmute yourself to ask questions or provide comments or your experience from other settings. That's very welcome. And also you can write in chat even during the presentation, and I will compile all of them. And you can either unmute at the end of the presentation, or I can read your comments for the discussion. So if there is no more burning questions or comments, I want to hand over to Dr. Chinwe for her presentation. Over to you, Dr. Chinwe.
Thank you very much, Miriam. So, good morning, good afternoon, good evening, everyone, depending on which part of the world you're joining us from. And I want to appreciate the SRS team for this invitation to present the findings of our research at your webinar. This research was conducted by an incredible team. I had an incredible team of researchers and supervisors. We wanted to understand how mortality systems are linked or integrated. By mortality systems, we mean the people, the processes, and technologies involved in mortality surveillance or in mortality function. We wanted to see how they are linked to ensure the availability of complete, timely, and reliable mortality data for public health decision making. And to do that, we conducted case studies of the United States, Colombia, and Zambia, examining the facilitators, barriers, and lessons of integrated mortality surveillance. We used the CDC defines mortality surveillance as the ongoing systematic monitoring, collection, and analysis of mortality data and the dissemination of information that leads to public health action. There was no prior definition of integrated mortality surveillance in the literature. So we adopted this definition that we crafted by understanding of integration to mean linking multiple data sources, people, processes, and technologies so that every death is not just registered, but is also analyzed for public health decision making. So that is our definition of integrated mortality surveillance that underpinned this study. We know that the receiver registration and vital statistics system is considered the largest source of mortality data. It should provide universal coverage of all deaths that occur in the country. It has 10 milestones from the notification of a death event when the death happens to the time when vital statistics are produced and disseminated. And mortality surveillance maps very well onto these 10 milestones across the 3 categories of activities: data collection and acquisition, and then internal systems and processes that include coding of causes of death and also quality control, and then data analysis and dissemination of mortality statistics as actionable information. So it's reasonable to conduct mortality surveillance within the CRVS framework. not as a parallel system. And this is the argument for integrated mortality surveillance that we adopted for the study. So why is this important? What exactly is the problem? Is because, as we all know, despite the public health value that mortality surveillance has, the CRVS, which is an integral part of mortality surveillance that provides the data that is used, has been underperforming globally. The 2021 score report of WHO shows that up to 40% of deaths that happen globally are not registered, and 60% of those that are registered are incomplete. Also in low and low income countries is even worse because only 8% of registered deaths have an accompanying cause of death. Hopefully these statistics would improve by the time the WHO publishes the next score report. I know they are in the process of doing that. Mortality surveillance is an essential public health function. It is a primary function for public health, and it falls within the first category of essential public health functions, which is public health surveillance and monitoring. Yet, according to the publication by Zuba and colleagues, essential public health functions are not enough for effective public health systems. When they operate in silos, they do not give the expected results. So those functions need to be linked, and that is not different for mortality surveillance. They proposed a typology of linkages that is across functions, various levels, and even sectors, and also linkages that happen internationally, which are required for the optimal performance of essential public health functions. Zuba et al. Also identified 4 categories of enablers, things that must be in place for those linkages in public health functions to happen. And they include having enabling policies, agreements, and legislation that support integration, having a supportive infrastructure, governance systems with sustainable financing and resources, and people and organizational culture. So for the study, we looked at some theoretical frameworks. We adopted the IVC DISC framework by Karaki et al. That demonstrates that for data to move through the information value cycle and be analyzed to produce actionable information, we must pay attention not only to the data itself, but also to the information system through which the data is processed and transmitted, including the people involved, the processes, and the technologies involved, and also the context within which the system exists and operates. This is the entire ecosystem for data. And using the Zuba et al.'s enablers that I described earlier and the IVC DISC conceptual framework, the CDC, through the National Center for Health Statistics, developed a theory of change for integrated mortality surveillance, which defines the desired future states for each enabler, those enablers that were proposed by Zuba et al., and also goes ahead to identify interventions that would lead to those desired future states. The goal is to achieve an integrated mortality surveillance system that provides timely, complete, and reliable data that guides public health interventions. And those interventions should lead to the ultimate goal of reducing mortality rates in any country. The overarching aim, therefore, for the study was to improve our understanding of how the CRVS and mortality surveillance functions are effectively integrated, linked through these case studies in the US, Colombia, and Zambia, using the CDC's theory of change for integrated mortality surveillance. And the specific aims include to describe how the CRVS and mortality surveillance systems are organized, the organization of the systems, and also the processes that are used. with our second aim being to qualitatively assess the degree of integration and related outcomes, identifying the enablers, linkages, and products of the various systems, while our third and final aim was to understand the causal roots of success in integrating mortality surveillance, addressing questions related to facilitators, barriers, and lessons from the three countries. So for our methods, we used a qualitative study. This was a qualitative study that used a phenomenological multi-country case study approach to examine integrated mortality surveillance in three very different settings. The three countries we chose were to help us facilitate our understanding of how the phenomenon of integration plays out in different developmental settings, with the US representing a high-income country with a well-established and advanced CRVS system, Colombia, an upper-middle-income country that has a fairly advanced CRVS system, and Zambia representing a lower-middle-income country with an emerging system. Our case analytical approach was not strictly comparative because of the varied context, but rather we used a country-specific cross-country case analysis that retained the different contextual nuances. Our research strategy involved reviewing documents, desk review of policy, guideline establishment, and strategic documents that supported the key informant interviews that we conducted and our data analysis. I conducted in-depth interviews of key informants that were purposively selected from the three countries, those that play key roles, senior roles within the CRVS and mortality surveillance systems. And we use these templates to extract information from the documents that we reviewed. We obtained relevant ethical and regulatory approvals and permits from the institutions in the three countries. The participant recruitment and data collection occurred from July to November 2025. We obtained written and verbal consents from participants before the interviews and recordings. The key informant interview was conversational. It was semi-structured and in-depth, giving an enabling environment for the participants to freely express themselves and share their views. The interview guide that we used were pre-tested, and the interviews were conducted through a secure virtual platform, Zoom platform. We provided the professional interpretation to Spanish speakers from Colombia, and we had the speakers sign confidentiality agreement before engagement. No personal information was collected from the participants, and the recordings have been destroyed, but the transcripts will be stored securely for at least 10 years. The interviews were transcribed verbatim in English and coded by 2 coders per country using in vivo and an iteratively developed codebook. The coders achieved consensus by prioritizing participants' proximal meaning. We tried to, as much as possible, to stay close to the language of the participant that was used to maintain the proximal meaning. We conducted framework and thematic analysis that used both deductive and inductive reasoning using the TOC, CDC's TOC for our deductive analysis. Described data flow processes were sent back to the countries, stakeholders in the countries for validation to ensure accuracy. So this is an example of the codes that we used for the TOC enablers and the desired future states. But we also extracted emerging codes inductively from the interview transcripts. Because this is a qualitative study, we're part of the researchers, were part of the study, and we acknowledge in our reflexive statement that the study was conducted by researchers that already had professional experience of the CRVS and mortality surveillance systems, including having prior engagement with institutions that are connected to mortality surveillance. And this influenced both our access to the participants as well as how we interpreted our data. However, the reflexive thematic analysis approach we used with paired coding, two people coding, and iterative dialogue in the coding process and analysis, and also grounding our coding and interpretation in the participants' accounts helped to improve the objectivity of our findings. So for our results, a total of 23 participants were interviewed across the 3 countries, 12 from the US, 6 Colombia, and 5 in Zambia. The number of participants interviewed reflected the complexity of the system structure in each of the countries, with the numbers helping to achieve data saturation with all the, when we were no longer extracting new themes from the interviewed participants, we know that we have reached saturation. So participants were experts and senior officials with similar roles in the CRVS and mortality surveillance systems across policy and programs. Some of them were policy makers, others were program managers and developers, data system and information and communication technology experts, and data use experts in the 3 countries. So for the first M, we will be showing slides that describe the organization and processes of the CRVS in the 3 countries. And we mapped the processes and evaluated them within the 10 CRVS milestones I presented earlier to see how they matched in each country. For the United States, death registration in the United States is very old, over 170 years old, but it took 83 years for all the states to be added to the national registration system. We're presenting this historical background so that it will guide our interpretation of the findings, especially if we're comparing the countries. The US operates a federal cooperative structure that is based on a federal state arrangement through contracts with the 50 states and 7 territories. The states register deaths that are guided by state laws is the state that owns the mortality data, while the CDC's National Center for Health Statistics, through its National Vital Statistics System, codes the causes of death and generates national vital statistics. They also provide model laws and standards that states can adopt. The NVSS purchases the mortality data from the states, while the states commit to specific data standards which are included in the contract. So it's a transactional arrangement that the federal institution pays to collect this data, while the states adhere to the standards that are in the contract in order for their data to be purchased. When mapped with the 10 CRVS milestone, the US system and the process maps strongly with the 10 milestones, with gaps and caveats coming from subnational variations and delays that come from medical legal investigations. The National Association of Public Health Statistics and Information Systems is an intermediary organization. They have an independent organization that represents the state's interest in federal negotiations. They also support subnational capacity building. And the various states share data among themselves and also with the NCHS through the STEVE platform. STEVE stands for State and Territorial Exchange of Vital Events. As at the time of the study, about 15 states had adopted the HL7 Fast Healthcare Interoperability Resources Standard that enable record level data transmission in real time, which is used instead of the batched files that other states use. So the real-time transmission improves timeliness of data. Provisional statistics are published early by the NVSS to guide mortality surveillance, and this is updated frequently as data comes in from the states, with the final annual statistics published the following year. So for Colombia, the system is almost as old as the US system, and it operates a centralized system. It has central coordination that is provided by the Ministry of Health and the National Administrative Department of Statistics, DANE. The Ministry of Health is responsible for medical certification of cause of death and death notification through the consolidated RUAF database. That's the Health database that is used in the country. Then it codes the causes of death and generates national vital statistics. When mapped with the system, it is important to know that the Colombian system has three independent data capture pathways. Number one, the Ministry of Health that captures deaths which occur in health facilities using the RUAF. Secondly, the medical legal pathway that uses the CIRDEC platform to capture external deaths and requires investigation, those deaths that require investigation, which they later transmit to RUAF. And thirdly, the mortality surveillance pathway coordinated by the National Institute of Health, INS, that uses the Civihila surveillance platform to capture notifiable deaths of public health importance. So those are the three independent pathways for data capture in Colombia. If you map the process, when we mapped the process with the 10 CRVS milestones, the Colombian process maps strongly to most of them, except for number one, death notification, which occurs through the multiple pathways that I described and can be delayed in rural settings. Secondly, data sharing that is still not automated between RUAF and Civihila is automated between CIRDEC and RUAF, but not between RUAF and Civihila. And thirdly, generation of vital statistics, which is usually delayed. So mortality surveillance data from Civihila gives that trade-off that is needed between speed and stability. They use that for quick public health decision-making, while the vital statistics is released later in the year. For Zambia, death registration is younger than the US and Colombia. Oh, I'm sorry, looks like I repeated US here. So the mapping of Zambia showed that most of the systems, if you don't mind, please, let me just end this and quickly pull up the Zambia story. Apologies for this.
And we are getting to continue the webinar. I just want to remind all our participants that you are welcome to write your comments or questions in the chat, but we'll also have time at the end of the presentation for your questions.
So apologies for this. Quickly share my screen. Okay. So for Zambia, the system, like I said, is younger than in the US. It dates back to 1964, which they inherited when they inherited the civil registration at independence. The Ministry of Health is responsible for facility-based deaths. They coordinate the medical certification of cause of death with the ZMPHI focusing on public health mortality surveillance. Data that is collected is by the Ministry of Health And the people that register their deaths, those families of the deceased will collect the medical certification of death and then move with that physically to the Department of National Registration, Passport and Citizenship for death registration. They code the causes of death and send the coded data to Zambia Statistical Agency, that's the ZAMSAT, that compiles the national mortality statistics. The system is highly fragmented with minimal interoperability and showing very low registration coverage. Family-driven and passive death registration hinders the timeliness of data and the completeness. But the Zambia system has just started implementing a community-based surveillance using sample registration system that supplements the CRVS data and helps them in making quick public health decision-making decisions, while they also have the longer term goal of making sure that they improve the death registration coverage in the country. So when mapped with the 10 CRVS milestones, most of the processes were weak. They did not map very strongly, and they had the weakest was with information sharing due to the poor interoperability across the data systems. But they had good quality checks. The quality control was strong, partial to strong. That was the strongest in the three systems. But like I said, it's important to interpret this, looking also at how long it has taken the various systems to get to where they are. So Zambia is making progress consistently in their system, but they still have a lot of improvement that they need in the system. So in a summary, bringing the three countries together, the strength of matching for all the time milestones was strong for the US. All of them matched strongly. Then for Colombia, the strength of matching for notification, information sharing, and the generation of vital statistics was strong to partial, while the remaining 7 milestones matched strongly. For Zambia, the strength of matching for information sharing, like I said before, was weak to partial, but quality control of vital statistics was partial to strong, while the remaining 8 milestones matched partially. For the second aim that qualitatively assessed the degree of integration and related that with the outcome we used here was registration coverage for this presentation. Participants in US describe their system as wholly integrated with information they get for mortality surveillance coming directly from the statistical system. And they described death registration coverage as almost 100%, over 99%. Colombian participants acknowledged that though the systems were integrated, it was not perfect because, like I said, transmission between RUAF and Civil was not yet automated. But the death registration coverage was still described as very high, over 90%. When Zambia participants were asked to rank the degree of integration on a scale of 1 to 5, where 1 meant no integration at all, and 5 perfect integration, they ranked it either 1 or 1.5, meaning little or no integration. And death registration coverage was said to be consistently well below 50%. So based on the participants' responses, it seemed as if systems with higher integration had a better death registration coverage based on the participants' perspectives. Now for the final aim, which sought to understand the facilitators' barriers and lessons of integration, some of the key facilitators and barriers within the policy and legislation included for the US, the contractual federal-state organizational structure, having centralized coding and standard operating procedures, and the model law. But variations in state laws and policies were repeatedly highlighted as a barrier. In Colombia, having harmonized regulatory frameworks and unique IDs were some facilitators. They use unique IDs to link data across data systems. But harmonization rules still has some variations across systems, and this was a barrier. Zambia has a legal framework for the CRVS, but it does not have a dedicated one for mortality surveillance, and they noted this as a significant barrier. For infrastructure, the US has a modern information communication and technology infrastructure that facilitates mortality data function, but they don't have universal health record identifier for linking data across systems, and they identified this as a barrier. The ICT variations also across jurisdictions was also noted as a gap. Colombia has implemented a digital transformation that enhanced their system performance, but persistent interoperability gaps and connectivity problems, especially in remote areas, hinder timeliness. Zambia has been growing its digital capacity, but fragmentation and the use of paper-based processes, as well as vendor locking of the FHIR APIs, hinder interoperability. They say that these FHIR APIs are too expensive for the country. US has long-standing relationships under governance, funding, and resources that improve governance, which is coupled with the NVSS and mortality surveillance systems being embedded within the CDC. The CDC is a public health institute, so having these systems embedded within the CDC was considered a facilitator. The use of funding to incentivize subnational compliance to standards was another facilitator. However, local level resource constraints remain a challenge in the country. In Colombia, the intersectoral committee, they have an intersectoral committee on vital statistics that facilitates multi-sectoral coordination and standards, but there's still lack of clarity across institutional boundaries, and these remain a challenge. Zambia cited good partner engagement and the mortality surveillance subcommittee as facilitators, but they still depend on external funding, and this was identified as a major barrier. For people and organizational culture, the NVSS employs highly skilled staff, and it has a culture of timeliness of mortality data, but there are still variations at the subnational level. A major facilitator that was cited by Colombia was the feedback loop. So they usually provide feedback to the stakeholders with strong community engagement, and this helps to build trust in the system among the stakeholders. However, there's still little feedback that is given to doctors who generate the medical certificate of cause of death, limiting their perception of its utility. So they identified this as a gap that needed to be addressed. Zambia has a committed workforce that have been trained through partner engagement, but they still have passive family-driven registration, which is considered a huge gap. Some emerging cross-cutting lessons from the study include recognizing that integration is not just technical, but it's also institutional. It requires sustained coordination with a clear definition of rules for all the stakeholders involved. Data requires effective systems to be accessible and useful. So it's not enough to just have the data. You need to have a functional system that enables the data to move from the place where it is generated to where it is needed for use. A core challenge that came out strongly for integration is how to make this to happen, to enable data to move seamlessly across systems for analysis and use. Also, incentives play a key role in enabling death reporting, especially for passive systems. So whether deaths and causes of death are diligently reported depends on the passive benefits to the families of the disease, as in the case of Zambia, or to the upstream staff like the medical doctors in more advanced settings. Therefore, it's important that feedback loops and community engagement are maintained. Another key lesson that came out from the study is that even though digitalization improves timeliness and efficiency, it requires governance to address coordination gaps and harmonize standards across systems. Some lessons also emerged from the recent COVID-19 pandemic that showed that public health crisis could actually present rare opportunities to advance mortality surveillance systems by attracting unprecedented investments. However, the participants, especially from the US, warned that based on their own experience, they cautioned that focusing mortality surveillance operations on these, using these fundings, unpredictable fundings, could be counterproductive because once the funding is gone, the system could collapse. So it has to be strategically used. And finally, the most important lesson is that sustainability requires domestic ownership, long-term funding, and investment in local human capacity. So aligning the cross-cutting lessons with the TOC integration enablers mapped them very well across the four enablers, with most of the lessons coming from governance, funding, and resources, policy, agreement, and legislation, and people and organizational culture. So while lessons around digital infrastructure were highlighted, they were not mentioned as frequently as the other enablers. So looking at the various systems, we see that US has a decentralized system. And the mature systems focus was not on creating new ones, new systems, but rather on aligning the existing ones and making them more interoperable, making them more efficient by adopting fire standards and other digital technology and systems that will, improve the timeliness of data. So that was the focus of the US system. But a critique of the decentralized system that the US uses, based on existing literature, shows that although institutional maturity enables integration to move seamlessly as routine business, the danger of such mature systems, according to Siseski et al., is the masking of subnational variability, which can create complacency about inequities that are existing at the subnational level. However, in favor of decentralized systems, Suda et al. Underscored the importance of adapting operational considerations to the context, for instance, the federated context in the US. For Colombia, the system has a centralized mortality function which promotes harmonization of standards and generation of a coherent national mortality statistics. However, concentrating authority and decision-making at the national level, at the central level, could present some reporting bottlenecks that could delay feedback to states and the ability to have timely mortality data for use. It can also blur subnationality and subnational capacity gaps. And as Godillo et al. Noted, those central rules are only as effective as the capacity of the territories to implement them. For Zambia, the country presents a case of using catalytic investments, mostly project-based, to trigger development in emerging settings. While partner-driven innovations, as in this case, may accelerate progress, they are not usually sustainable, and they often require that local systems will absorb recurrent costs. So this approach was reported in the literature as being common in low-resource settings. And the Open Data Watch warns that such systems that prioritize short-term projects over long-term ones risk prolonged vulnerability. They are prone to external funding shocks. Also, the literature recommended that verbal autopsy programs like the one in Zambia should not be conducted in isolation, but should be linked to civil registry system to improve national death registration coverage. So in summary, two pathways emerged from the study for strengthening integrated mortality surveillance across systems. For integration to be routine, the system needs to clarify roles for all the stakeholders involved, formalize coordination, ensure that there is a designated body that is responsible for convening the various stakeholders, and support shared standards. Secondly, to reduce operational friction, the system needs to improve information flow through digitalization, interoperability, and investment in workforce capability. So while co-investment in both pathways is needed in every system, emerging systems could benefit more from prioritizing investments in the first pathway, making sure that the governance structures, the policies, the legislations, and the standards are in place to support digitalization in the system. Advanced systems, on the other hand, could be more interested in testing innovative digital solutions because they already have the first pathway cut out for them to make their system more efficient and timely, while maintaining the already existing governance and policy instruments and structures. So in summary, the lesson that came out here strongly is that investments in technology should be paired with investments in organizational capacity, especially governance, financing, and training, so that integration can be sustained and scaled. Some lessons also came out that are transferable. Number one, the three countries have something to learn from each other. The US can strengthen its community engagement by learning from Colombia's feedback loop. US can, provide more feedback. That is a weak area that was observed in providing feedback to various stakeholders. They have a central system where people can log in and get what they want, but that communication gap is still there and can be breached by NAFSIS. It can also address equity issues by following Zambia's example of adapting technology to different area needs. Zambia uses offline technology in areas that have low internet connectivity. So this is an example that can be adopted. Colombia can improve interoperability by learning from the US and also improve fairness in modernization in rural areas as shown in Zambia. And Colombia's routine data reconciliation is a lesson for Zambia. They can use that in managing their fragmented systems. And Zambia can also learn workforce integration from the US. So some cross-cutting and context-specific recommendations are presented from the study, but for this presentation, I'll focus on the cross-cutting ones. We've been able to present the specific country-specific ones to the participating countries. Countries should formalize institutional coordination mechanisms and move from project-based to more sustainable financing approach. Continuous training in data governance and analytics are very important and they are needed. And systems should align community incentives with the expectations from the communities. We have to incentivize cooperation and collaboration with communities. Modern legal and policy frameworks are needed. Most of the legislative and policy frameworks are very old and they need to be revised and adapted to keep pace with digital and integrated surveillance practices. And also interoperability protocols and standards have to be adopted to improve timeliness and efficiency. So in summary, the US shows that maturity can make integration routine, but it requires continuous engagement and investment. Colombia's centralized management provides national coordination, but it still requires to manage institutional boundaries that come from different mandates. Zambia shows that technical capacity and digital platforms promote integration only when they are matched with local governance and operational standards. So our study had some limitations. As a qualitative study, we know that the purposive sampling we used affects the ability to generalize our findings. It might not be representative of similar settings and systems. So self-reporting also by participants is prone to recall and social desirability biases. Participants may want to present their work or institutions in a positive light, and we needed to verify some of the claims through quantitative indicators. Comparing three different countries requires caution, as we had established, because of the contextual differences. Also, the study captured systems at a specific time in period, which may change after the study. Nevertheless, our study has some strengths. It provides solid analytically grounded accounts of integrated mortality surveillance in the three countries, investigating both country-specific and cross-cutting factors that guide system improvement. And the reflexive analysis approach we used provides credible and transparent insights that could inform policy and future studies. In conclusion, This was a comparative study that provided insights and lessons for countries at different stages of developing their CRVS and mortality surveillance systems, and contributes to the growing body of knowledge on improving timeliness, completeness, and usefulness of mortality data for public health. For our future steps, we have already presented our findings to the participating countries, and we're hoping that they'll be able to look at it and hold policy dialogues or develop policy briefs to implement the recommendations. We will publish manuscripts from the study, and cross-country learning platforms like the SRS team that you have is recommended for countries to exchange ideas on how to strengthen integration in their systems. A study that quantitatively assesses integration as an abstract construct is recommended. It can identify measurable domains from our study, and also implementation research that tests the feasibility, sustainability, and equity in access and use of the digital transformation projects that are currently ongoing in the 3 countries. So the study was funded, the Colombian and Zambian studies were funded by the Data for Health Initiative through the CDC Foundation. And like I said before, this was supervised by a dissertation committee with GW, Harvard, and CDC, National Center for Health Statistics playing key roles. Dr. Erin Nichols was my preceptor and guided me through the process. So thank you very much for your time. Apologies again for the interruption that we had. Happy to take your questions and comments.
Thank you. Thank you so much, Dr. Chinwe. That was a very interesting study, and thank you for sharing the methodologies and the findings with us. So I will open the floor for any questions. If you have any questions or comments, you can raise your hand and unmute yourself. We already have a question in chat. Maybe we can start from there, and if our participants, they want to raise their hand, then we can go next. We have a question from Agbezi. A continued challenge in Zambia, as in most LMICs, is the poor completeness. Without higher coverage, integration will lack priority. What lessons can Zambia borrow from the US and Colombia to improve completeness?
That's a very good question. Thank you so much, Agbezi. Yeah, like I said, these are 3 different contexts, so we don't want to be ignorant of the fact that what works in one system may not work exactly the same way in another system. But there are some very good lessons that the systems can learn from each other. For Zambia, you mentioned correctly the issue with completeness. And I think it's because the system is still paper-based in many instances, and the passive nature of the system where you need the family of the deceased to go by themselves to, collect the medical certificate and then go to the Department of National Registration, Passport, and Citizenship to register the death. And they only do that when there is something to benefit. If there is a claim, that the deceased has, that the family needs, then that is when they go to make that claim and register the death. But if there is nothing to claim, for instance, for a disease that maybe was not working or has any formal claim, then that death may not be registered. So that is a huge problem. The system has to find a way of automatically registering deaths without requiring the family of the deceased to be the drivers of the system of registration. So that is one key lesson that can be learned. And also finding a way of, they have the Smart Care Pro platform is the health digital platform that is used for, healthcare in the country. That can be automated and made interoperable with the INRIS that is used by the Department of Passport Registration, National Registration of Passport and Citizenship, DNRPC. So if that is automated, then it means as death is happening and they are registering it and generating the medical certificate of cause of death is automatically transmitted to the civil registration institution, the department that can now register and automatically generate the death certificate. So that can improve completeness. Full registers, it will no longer be dependent on the family going to register by themselves. So that is one other less. But you can agree with me that all these requires investment, domestic financing of the process, for this to happen. They are in the process of adopting the API and the FHIR standards that will enable interoperability. But that is expensive and vendor locking is affecting it. So they still rely on external funding to be able to do that. So that is another area that, if they are able to address, then they can compare with the other countries in completeness. I hope this addresses. There's still a couple of recommendations that were made that are specific to Zambia, which we are happy to share. We've already shared it with the country. I hope this addresses your question. Thank you.
Okay, I don't see Agbezi, but if you have like any other comment, Agbezi, you're welcome to unmute yourself. Otherwise, we can.
Thank you so much. I appreciate the response from Chinwe. Thank you so much. Yeah, I agree with you. I think the systems in our country, Zambia and others, should find a way to register those events rather than, expecting the population to do that. I mean, the U.S. has, I wondered, I mean, the U.S., I haven't seen as a process where the US went from 0% to 1% to 50%. So, I mean, the system was set up in a different way. It's a mature system, but it's not a passive as in Zambia, for example. So I agree. I mean, until we find a way to get our populations to register those events rather than waiting for the population to do that, well, we'll still be struggling with poor coverage. Thank you so much.
Yeah, and just to add to what you said, it's important that countries they discuss these problems, that they have a platform where they meet. I know that this Zambia has the subcommittee that brings stakeholders together. But one of the clear challenges that came out is that communication is still not strong as it should be. So they want to be able to meet more frequently across the sectors to discuss this problem because you need creativity to come up with it. You mentioned US. US has a very complex arrangement that would have been more difficult to handle. But I think they came up with that creative, innovative way of using contracts, because the federated system, the states are autonomous, they can't, the federal government cannot control the state, so to say. There is no federal law, single federal law that governs how they deal with this data. But yet they came up with that contractual arrangement that, okay, the states need money to build their systems and we need their data. So we buy the data and they adhere to our standards. So that has worked for them. So other countries can also think about what works for them, how Zambia can, incentivize participation and how they can. Another thing that came up from Zambia was that the DNRPC has budgets for the CRVS captured within the appropriation budget, as part of federal funding. But there is no such budget in ZMPHI for mortality surveillance. So if it is seen as an integrated system, then perhaps they can come up with a plan where the budget covers the entire thing and not just the CRVS. So that is another strategy they can use to incentivize funding for the system. Thank you for that.
Thank you. We have 2 minutes. But we have more comments and questions coming. So I will read them. And if we don't have the time, then we will close at the top of the hour. But I would encourage everyone to stay connected with Dr. Chinwe and reach out to her via email. Or if you are Dr. Chinwe, I hope you are already in the SRS community of practice. So there is a community there, so everyone can stay in touch with you if they have any questions. But there is one comment from Kingsley, USFHIR, interoperability could be a good lesson for Zambia. And Zambia scaling digital tools to all provinces and districts would be a good lesson. US put effort in modernized systems in the jurisdictions. Thank you, Kingsley. And we have questions from Zainab. Sorry that I'm reading all the first names. What parallel systemic changes can be brought about in the CRVS system while implementing SRS? And there are more congratulations. So, Dr. Chinwe, in 1 minute, if you want to answer questions from Zainab.
Yeah, thank you very much. I'm very happy to connect with everyone after the call. I know I took a few of our minutes, so I can give back those minutes in answering the questions. So for Zainab, thank you. It's a very good question. Yes, like we observed in Zambia, the use of SRS as a catalytic way of, generating data for mortality surveillance, but also feeding back to the CRVS to help in national coverage of death registration. So there are lots that can be happening, well integrated, but also in parallel because they are working in different aspects of the continuum for mortality surveillance. So the CRVS, like we said, digitalization, adopting the FIRE standard, and also finding a way of linking the data that is coming from the SRS at the community level back to the CRVS, the DNRPC system. So if this is automated, digitalization is very key. But like the study established, that is not the only thing. In fact, the main thing is to even have the system in place that allows you to digitalize effectively and enables the people in the various systems to be able to work together. Also enables the processes to be linked so that they are not operating in silos and generating different data, sometimes causing duplication. But digitalization, like the INRIS that is used by the DNRPC, helps also in identifying duplications and dealing with that and improving the quality of the data. So if there is a way of linking the data that is coming from the SRS back to the CRV, which I know currently they have an extra form they complete, that will be submitted to the DNR. Or as good as that is not perfect. If that is not digitalized, it will be a problem. And then also, secondly, SRS is SRS. It's sample based, so to say. So it does not give you the full coverage of the entire country. So planning to scale your SRS to cover more communities and eventually become a whole country approach for communities that most of the deaths happen outside of the health facilities is a key way to improve death registration coverage in such settings. I hope this addresses your question, Zainab. Thank you.
Hey,
Thank you very much. That does. Thank you.
Okay, great. Thank you, everyone. Especially thank you, Dr. Chinwe, for your presentation and sharing your experiences and for the engaging discussion here. For the next webinar, we will keep you updated about the time and the schedule that we will have. So until next webinar, I wish you a great time. Bye, everyone, and have a good day or evening.